ऐसा ऑन हो जाए।
ये आ ही गए, अभी इनवाइट करने की जरूरत नहीं, सारे बैठ गए। डॉक्टर शंकर, लेट्स स्टार्ट।
डॉक्टर एंड्रेस, first, I've told him.
A very good morning to all the distinguished participants. May I request you all to take your seats? Please, I am asking all the participants to keep coming forward so that it fills up first, the initial seats get filled up. So we had a very exciting day yesterday where we heard about the impact of HTA on affordable healthcare in India, integrating cutting-edge innovative healthcare technologies in health systems with HTA supporting value-based pricing and procurement of drugs through HTA, and a very exciting panel discussion to discuss barriers to innovation challenges with patent filing.
Good morning, everyone. Thank you, Dr. Geeta, for that recap of yesterday's session. We start the day two with same excitement and enthusiasm. We welcome you to the session on advanced methodologies for health technology assessment. I am sure the topic is of interest to many research scientists who are present here from the resource centers and resource hub, because this is a topic that we all think about and also try to expand the scope and horizon of this particular methodology part. So when we look at the competencies of any person or a skill that we require, we move from T-shaped competency to V-shaped. So what do I mean by T-shape? The T-shaped competency is where we know a little bit about everything, but a particular topic we are very sure and we are very confident about. But as the ecosystem of HTA progresses, now it is time to increase or move from T-shaped to a V-shaped competency. What do we mean by V-shaped competency is to broaden our views and start doing more work, in-depth work in that particular area. This is the background of today's session, and we are very delighted to have a distinguished panel with us, the chairpersons with us, and we'll start the session as soon as possible. I'm very happy to welcome the chair of the session, Dr. Andres. He has spoken yesterday. As we all know, he is the managing director of Institute of Clinical Health and Effectiveness, Argentina. Thank you so much, Andres, for joining us and accepting our invitation. The stage is yours. This will be a keynote speech for almost around 10 minutes, and then we'll move to the second keynote speech. Thank you. Over to you.
Thank you. Good morning. I am not sure how to change. Can I change the presentation from here? Perfect. Okay, thank you very much. Again, it's a pleasure to be here. I will briefly comment about some specific methodologies. As you know, cost effectiveness is a very important dimension, but of course it's not the only dimension that is taken into account, and there is a particular aspect of interest mainly for low and middle-income countries, that is equity and how health technologies can impact equity, maybe increasing inequity or maybe in some cases decreasing inequity. So if I use the pointer here, I'm not sure if you, yes, okay, here. So this what I'm showing here is like a traditional cost-effectiveness analysis. So it's like looking to something in one dimension, no? If we do a cost-effectiveness analysis, we will know if, suppose that we have a range of policies, if we have different interventions, well, this will give us information of what is intervention that is more cost-effective or less cost-effective. And this information is very useful, but as you can see, it's only one dimension, no? It's one piece of information. So there are new methods, probably you are well aware of that are, a generic name is extended cost-effectiveness analysis, and these methodologies provide a new dimension, a new criteria. No, it's not only whether something is or not cost-effective, but we can also analyze what is the impact on equity in the healthcare systems that will be the result of including that technology or that intervention in the benefit package. And if we have these two pieces of information, if we have the information on the cost effectiveness and the impact on equity, we can represent the results in something like this. This is very similar to the cost effectiveness plane, but it's not the same. Here we have this horizontal axis where we measure the impact on equity of including that new intervention in the benefit package. To the right, this means that we will improve the equity of the healthcare system with this intervention, and to the left will mean that we will, the inequity will be worse. And on the vertical axis, we measure the efficiency, the cost effectiveness. And as you can see, we have four options. So the ideal is in the upper right quadrant, where we can find interventions that are cost effective, increase efficiency, but also improves equity. And of course, there will be trade-off here, so I will show now some examples. Well, today we have a speaker from Thailand, but I have this very nice example from Thailand. I remember that I visited Thailand around 10 years ago, and we went to a hospital and they show us some examples of the decision-making process in Thailand, and I found this example very interesting. I hope there are no mistakes in my presentation, you correct me. But in Thailand, they performed a cost-effectiveness analysis, and they found that dental implants, instead of removable dentures, are cost-effective. However, at that time, a large proportion of the country still lack access to a standard of care, maybe rural population, no? So they decided in that case that coverage, they will not include these dental implants because that will increase inequality, because it was a new technology, it was cost-effective, but it will be available just for those in large cities. So it is an example of intervention in this upper left quadrant, an intervention that is cost-effective but harms equity. And also this very good book from WHO on how to make fair choices in the path to universal coverage. And again, this Thailand example is a good example of what these books mention as an acceptable trade-off, no? It's not correct to expand coverage for low or medium priority services before there is near universal coverage for high priority service. So actually, this is a very important dimension. And regarding methods, well, this this term of equity, informative, cost-effectiveness analysis is a kind of umbrella term to describe any kind of a study that use cost-effectiveness analysis to provide information about health equity beyond just the impact on health. And there are two main categories. One is the extended cost-effectiveness analysis that was developed by the disease control priorities. And the extended cost-effectiveness analysis examines the social distribution of the health effects and also the financial risk protections. I will show one example now. And another big methodology is the distributional cost-effectiveness analysis that was developed by the University of York, and this approach examines the distribution of health benefits and opportunity cost. So this is an example of extended cost-effectiveness analysis. We have usually, we can have just one outcome, like health gains or private expenditures averted or financial risk protection, but doing an extended cost-effectiveness analysis, we can analyze these different outcomes in different sectors of the population. For example, this is a paper that examined the rotavirus vaccine in Ethiopia, and this paper found that there were higher health benefits for the poorest and higher financial risk protection for the poorest. So it is an intervention in the upper right quadrant. No? It's something that is cost-effective and also decrease inequity. This is an example of distributional cost-effectiveness analysis comparing in the UK a screening program for bowel cancer. They were comparing two screening strategies. One strategy is just ask everybody to go to screening, a universal approach, and another one was a targeted approach, trying to find those at higher risk. And as you can see here, those most deprived were the ones with the lower life expectancy and also with the lower screening rates. So this target strategy, the effect of the target strategy reduce inequality but produce less total health than universal strategy. No, it's an example in the lower right quadrant where there is something that is less effective because the universal screening was more effective, but this target screening was a little bit more less effective, but also improves equity. So there are some trade-offs. No? So the key message here for decision makers is that some decisions will involve trade-off between improving health and reducing health inequity. And now very briefly I will show some results from Argentina. Well, maybe you don't know, but the first time that I came to Delhi was around 20 years ago. And I was invited, but at that moment, by Professor Srinath Reddy and Dr. Prabhakaran, because they give me a small research grant, and I came to Delhi to receive training in, it was about study design and statistical methods. And also with that small grant, we started in Argentina to develop a model to evaluate tobacco burden. And well, a couple of years later, we published this paper with Professor Reddy and Prabhakaran and other colleagues. That was a paper that analyzed the impact on families and patients of cardiovascular disease in India and Argentina. I think it was Tanzania, one more country that I can't remember now. But it was very interesting for me, and I am very grateful to India and to the Indian institution that provide us this grant at that moment. And finally, we developed this model to analyze tobacco. It's a quite complex microsimulation model. It's an individual-based microsimulation model. We produced more than 25 papers, and we applied that model in 12 Latin American countries, in Nigeria, and last year we applied in India, so it was very interesting. Something that started in India, then came here again. I think it's a very nice example of South collaboration. We applied this model with a group of the Institute of Medical Science and Research in Kochi, in India. This is a photograph of Ariel, my colleague, working with the collaborators here. And I hope that this will be published very soon, but applying this model in India allows us to analyze what will happen if India raises taxes for tobacco, and what happens if raise taxes for smokeless tobacco. And as I mentioned, this tobacco model also is one example where we apply extended cost-effectiveness analysis. For example, these are some of the results where we analyze the burden of disease.
Excuse me, Dr. Andres, one more minute, please.
Sure.
Thank you.
And as you can see, in the poor quintile is the larger burden of disease, and this is even more interesting. This is the economic burden of disease. This includes direct medical cost, out-of-pocket expenditures, productivity losses. And if you look here, it seems that it's quite similar for all the quintiles. No? These are the poor, these are the richest. But if you analyze this economic burden as a proportion of the income, you can see that the burden is much, much more larger among the poor ones. Well, this was just an example. This methodology also, for example, allows you to analyze the cases of poverty that can be averted. And this is another example of applying extended cost-effectiveness analysis to a screening policy for muscular atrophy, also showing the distributional effects of this policy. So this is an old figure, but it's very useful. You can see here a decision-making that is in this step of efficacy, and he thinks that he can see everything from there, and it's better to go one step up and another one, and another one. No, if you can use effectiveness data, cost-effectiveness data, equity data, probably he will be able to take better decisions. So thank you very much.
Thank you, Dr. Andres, for that presentation, and also highlighting the importance of including equity analysis in our efficiency analysis. Thank you so much. Over to you, Dr. Geeta.
Address from Dr. Preeta Paun. Dr. Preeta Paun is heading the research unit in HITAP and has been with HITAP since 2007. She was awarded HITAP Scholarship for Masters in Health Economics from University of York, and she was awarded PhD from University of Leeds. Dr. Preeta Paun has a special interest in HTA for drugs, for osteoporosis and renal cell carcinoma, and for dengue vaccine, and for screening programs for TB and diabetes. Over to you, Preeta.
Thank you very much. Good morning, everyone. Good morning to our distinguished guests and esteemed colleagues. It is truly an honor for me to be here today at ISHTA 2025, and I would like to sincerely thank the organizing committee over there and here for the opportunity to representing HITAP Thailand. So it's been a privilege to witness the strong leadership and political commitment and rapid progress of the HTA community in India. We are all here because we share the same common goal to improve life through better evidence-informed decisions. And of course, this is Sunday morning. I know that you all trade off between relaxing Sunday and academic conference. So thank you very much for the audience to be here today. So let's discuss about the session here. Do you think that decision-making is an easy process? No, right? Front row, distinguished guests said no. I also believe that decision making is a very tough choice, especially in low and middle income countries where budgets are tight, resources are limited, reliable data can be scarce, and policymakers face difficult trade-offs every day. But yet, what we want to do here is we want the same goal, is to improve our population, quality of life, expanding life expectancy, and provide health care for all. And not just to provide, but to ensure that our healthcare system is sustainable, adequate, fair, and efficient. So this is the common aim of our goal here. So I think this kind of symposium is very important. It provides a platform for us all to exchange knowledge and strengthen the HTA community so we can shape the better future. So this is a brief summary about me. I also current health economic working groups and also editorial team for the Thai Health Technology Assessment Guideline in Thailand. So happy to share more thoughts about that later on. But today, I would like to focus on 3 key messages that I would like to share with you. HTA is adapting. As we navigate through the era of rapid technological advancement, it is essential to recognize how HTA can serve both a traditional tool for reimbursement decision making and also a catalyst, like you gave an example yesterday, that we can improve the innovation through committing HTA at the early stage of development. So let's see here. HTA now can be used in the life cycle of health technologies through research and development, market authorization, investment, or even disinvestment. At HITAP, we focus now more on the early HTA because in Thailand, a lot of funding goes through this innovation where there's a lot of shiny object, but in fact, they might not be reflecting the need of the population. So what HTA can do is prioritizing the need of the population first and see which innovation that can help solve the problem, closing the gap. And also, we also look at the disinvestment. What does it mean? Even though we do HTA, we do economic modeling, we adding on benefits, right? And we hope that our healthcare system is efficient, but when in fact it's not. So we can use HTA to identify the inefficiency in the healthcare system. So in this example, I highlight the low value care. What does it mean? The low value care is like the services that doesn't really provide benefits to the population. For example, the C-section in Thailand. Anyone here knows about having a C-section in Thailand? Sometimes they don't do it based on the medical reason. Sometimes it's based on luck. Like, oh, you need to give birth on this specific date and specific time in order for the baby to be fortunate. Anyway, don't laugh. This is true. So we have the efficiency in the healthcare system, and the C-section rate in Thailand is really high. So we need to look at it in another angle and see how can we improve this inefficiency. So this is the case example of using the early HTA to identify what we call target product profile. What does it mean? It means that instead of you let the innovator do all that things, right? We as a HTA researcher, we help them to think about what should be the target product profile of that innovation. For example, if it doesn't really like produce cost effectiveness result, what feature that particular product could be improved at the early stage of the designing phase. So instead of letting the innovator do all those, innovation and testing in the clinical trial and then end up with cost ineffective intervention, we can guide them early on in the development stage. And for the next example is the low value care. This is the way that we use the data to identify what is the inefficiency in our healthcare system. So when you talk about the data, my second point is the use of the real world evidence. So in fact, you can use the real world evidence and real world data throughout the stage of health technology development. However, the real world data these days, it often comes at the later stage, as you can see here in the slide. If I can have the laser. So as you can see here, these are all the real world data that is being used at the moment. And when you look at the real world data, what does it mean? It means the data that collect during the routine delivery care. So meaning that it doesn't require effort. I mean, when you are a researcher, you need to do all those ethical clearance, do data collection, but this kind of information you gathered from maybe disease registry that already established, or electronic health records, electronic medical records, or claims database. Even with the patient-generated data, you can also use it as information to inform the development of the health technologies, and also variable device. I have it here. So these are very important data and information that will guide us to the next phase of preventive care in the future. Also, biobank is another set of data that we can utilize as well. However, when we talk about data, we all know that data is the new oil. However, it has to be refined. And we do need to refine it as well. Otherwise, oil is just oil. We cannot use it. Similar to the data, this is the data-driven research informed policy in Thailand. So we use the big data from the 3 insurance claims, the UCS, CSMBS, and SSO. So the 3 main public health insurance. And we help guide the health system service efficiency development. We look at the supply side and also demand side. And also we identify what is the need and what is the utilization of the current situation. And also we use it to inform the health benefit package development. So we look at the utilization, the claims, and also the feasibility information to inform the development of the benefit package in Thailand. So this is just the sample of the data set that we have, and we can analyze the number of telemedicine service during the COVID. As you can see here, it increased a lot in 2023 since the Ministry of Public Health announced the telemedicine policy. So you can see the trend, you can see the utilization, you can ask me, and so what, right? So within this information, you have all those ICD-10 codes, so you can further investigate on, so which kind of utilization patient use for telemedicine. In Thailand, we use a lot on mental health. So right now, we can see that maybe there's a gap in the health system. Maybe mental health patient in Thailand doesn't really want to use the face-to-face services. Maybe they prefer the telemedicines. So this sparked the new ISHTA project on telepsychiatry, which we are currently doing evaluation on the service provision. So as you can see here, these kind of information are very valuable, but what you can do about it is the matter of the choice, and also you need some form of training as well. So I can show you this information. When you look at the data, it looks like, we just like, yeah, let's just plus minus do equation. It's not that. This is the expectation when you talk about the data. But in fact, in real life, the claim data set is very untidy. In HITAP, you spend like more than 6 months to clean the data set and be able to use it.
You have 2 more minutes to go.
Yeah. Okay, so how to deal with the data and how to adjust with the biases. We have the recommendations here, published here. You can go look at your own pace. So let's move on to the next point that I want to address. This is the last one. And I want to give this like a brief framework about how to define value of the health technology. So let's think about this health technology. Typically, the scope of economic evaluation, we look at the quality gains, right? Net health costs, productivity loss, maybe. So these are the three main components. But when in fact, the value of that particular technology may not be only these three components. Yesterday, we talked about financial risk protection. This morning, Andres talked about the equity. So how do we capture all these value for that particular health technology? And I would like to touch upon our new initiative, it's the Green ISHTA. So basically, all these healthcare interventions, they come with costs, and also they come with carbon emission. Throughout its life cycle of its generation, it produces carbon emission maybe more or less than one another. We would like to incorporate this into our decision-making process. We don't want to just only look at the quality gain of the patient, net health costs of the health system, or productivity loss of the family member, but we want to look at the global health view. And we already mentioned about the equity, efficiency, impact pain, so I'm not going to go into detail about it. But as you can see here, all these values are quite normative. We need to capture, we need to make it quantifiable. But right now, we're still in the phase of developing the methodology. One of the examples is the distributional cost effectiveness analysis that we can show to the policymaker. Okay, we have efficiency, but maybe it's not fair. So for example, in Thailand, the case of renal replacement therapy, it falls under this quadrant. So it is cost ineffective, but it does a lot of improvement in equity. So we can use this as a tool to guide our policymakers to justify maybe the intervention not need to be cost effective, but it gives other benefits to the population. So my key takeaway is that HTA is not just a one-time thing. It's not just for reimbursement process. It should be integrated along life cycle of the technologies. We can leverage real-world data for more adaptive and more context-specific priority setting and decision-making process. I've heard a lot about yesterday. You have a state, the national decision and also the state decision. You can utilize your own data set and see what is the need of your own population in particular state. And the concept of value is not static. It must be contextualized and localized based on your population need. And lastly, I would like to stress the point that we need to continue invest in capacity building. As you can see here, there are many ways to capture the value, but we do need resources, we need networking. At ISHTA, we face with capacity building as well issues. We train and then they left. This is common everywhere, but how we can utilize our network, strengthen the South collaboration, and also share our knowledge and learning together to strengthen the HTA capacity. Thank you very much for your attention.
Thank you, Dr. Preetapon, for highlighting the need to integrate HTA in the entire life cycle of a technology, and also leveraging real-world evidence for a more context-specific priority setting and decision-making process. So now over to you, sir.
Thank you, chairs, for your keynotes speeches. Now I would like to invite Professor Sankar Prinja, a very good friend of mine, Professor of Health Economics, Department of Community Medicine and School of Public Health. He needs no introduction to this audience. So to deliver his talk on advanced economic evaluation in HTA, moving beyond cost effectiveness. Dr. Shankar, you have 8 minutes, please. Thank you.
Yes, sure. Thank you. I think coming after such interesting keynotes is always a challenge, but I think that the stage is set in a very apt manner, trying to highlight some of the most important issues that, that we're thinking and discussing today when we're talking about advancing these methods. I think that there might be a lot of commonality, so I'll try and skip some of those points that I've tried to mention, but the major part of my talk is going to focus much on this issue that decision making when the evidence comes to policymakers is not contingent upon only one criteria. So we are since yesterday talking about doing cost effectiveness and generating an estimate of cost effectiveness ratio, but that alone is something which is not the only deciding factor when a decision maker sits down on trying to make a decision whether to fund a given intervention or not to fund, or whether to include a new therapy in the standard treatment guidelines or not. So the decision making will always involve multiple criteria. And three, perhaps the most important ones that we heard since yesterday have been that maximizing the health given the available resources, which means cost effectiveness. It also means improving equity in terms of utilization, something that I think Dr. Andres tried to highlight. And the third, in trying to reduce out-of-pocket expenditure and improve financial risk protection. So which means that we need to expand on the horizon of the analysis that we are doing, not just focusing only on generating an estimate of ISER, but also trying to generate evidence on these other value connotations for a given healthcare technology or intervention. But towards the end, I'll try to again re-emphasize that while we continue to think in terms of advancing and generating more and more evidence on newer value elements, we need not necessarily forget the important message that Professor Vinod Paul gave in his opening address, that we need to continue to focus on quality, generating the evidence which is of top class, such that the decision makers feel confident in using that evidence. So just to reiterate, there's been a systematic review that was undertaken which showed that what are the different criteria based on which decision makers generally take those decisions. So while cost effectiveness does feature into one of those criteria, but there are other important criteria that also are being considered. And while we have been talking about this issue of cost effectiveness analysis and generating an estimate of cost effectiveness ratio to make decisions, but decisions may not solely be based only on this one single criterion. And I'll just give you an illustration of how perhaps the availability of budget and the extent to which the current intervention imposes pressures on the budget, or in other words, what we tend to refer to as budget impact analysis, becomes an important consideration. So we were doing this study in India, looking at one of the antiviral drugs that is used for treatment of hepatitis C infection, which is velpatasvir, and we found that the drug is very cost effective. But if you give it to the entire population of all those who are suffering from hepatitis C, it imposes an increase in budget which is in excess of 60%. So the state government's budget on that program had to be increased by 60%. Now that's a significant ask in a given year for any decision maker. So that then the analysis was further revised to see that, okay, what if there could be a specific subgroup who could also benefit more, and where perhaps the impact on the budget is not going to be too much. So what we then found was that if you give it only among a subgroup of the entire HCV population, which are the ones who are suffering from cirrhosis, then it still remains quite cost effective, but the impact on budget is to the tune of just about 5 to 8%. So the decision then that was made was not to give it to the entire population, but in a subgroup of those who are suffering from HCV. So it is kind of balancing both your cost effectiveness and the extent of impact on budget. So here I'm saying that the budget, and there's another example which comes from the Thai context, and I've tried to borrow this from one of the messages that Dr. Yot gave in one of his talks. This was another analysis that was done for a rare disease, which is Gaucher's disease. The drug that was considered for treatment and for inclusion in their essential drug list was found to be not cost effective. But given that it is the problem occurs only in a very small set of patients, which are mostly belonging to vulnerable population, so the budget impact is not too much. And the fact that it is going to benefit the ones who are the most vulnerable, the poor, that means that you are going to even improve the equity in terms of outcomes and the distribution of care. A drug that was not found to be cost effective was still included in the NLEM. So two examples, one where you have a drug which is cost effective, but then they're still not included in the therapy for the entire population based on budget impact. Second, where a drug not found to be cost effective, still included because it had a very limited impact on the budget. So that takes me to the next thing, that we need to incorporate this important element of analysis in our HTA assessments. And in India, we have developed these guidelines for undertaking the budget impact analysis. The reason why it becomes even more important to have more contextual local guidelines for conduct of BIA as compared to any other international guideline that you could take for a cost effectiveness analysis is that the local situation in terms and the context in which we are financing our healthcare services and delivering our healthcare services makes the conduct of budget impact analysis extremely local and a contextual use case. So these are some examples. So for example, if you look at that, who is going to be the choice of provider? Is it going to be the government or is it going to be the private sector with the introduction of the new intervention? The question around how does it impact on the budget changes very significantly, because if you are paying to the public sector, perhaps there would be an incremental marginal cost that the public system has to pay. Whereas if the provider is going to be a private sector, then perhaps you might need to consider reimbursing him the full cost, which may mean that the impact on budget is more. Similarly, whether the delivery is more in the context of a vertical program versus it is horizontally integrated into your care delivery pathway, that has an impact on the budget, because if there's the same set of human resources who are in addition delivering the additional services, while from an economic perspective, doing a cost effectiveness analysis, we have to value their time, but from a budget impact analysis, perhaps the implications would be slightly different. And similarly, whether even in the context of when you are operating an insurance program, whether you are doing it in a trust mode versus an insurance mode, that makes a difference in terms of how you are going to value the additional costs that would impinge on the budget. And finally, there might be several resources in delivering a particular program that might be coming from other sectors, which perhaps if you're doing a budget impact from a health systems perspective, they may not be as relevant. And as a result, looking at which sector is allocating how much resources may also become a relevant question from a BIA point of view. So again, the point that I'm trying to emphasize is that beyond the generation of an estimate of an ISER and cost effectiveness, undertaking a budget impact analysis is a crucial piece of evidence that decision makers require when making decisions, because at the end of the day, while your answer to the fact that it is cost effective, yes or no, only gives them a one decision point that whether it is worth the value for money or not. But in order to incorporate it into the program, they need to have a figure how much they expand their budget. So that becomes an important consideration. I'll not spend time on this. I think Dr. Andres has given enough description and explanation of this fact that incorporating equity is important. And he has also given several illustrations that there are many methods of incorporating equity into the analysis, which could be extended or distributional cost effectiveness analysis. But the key takeaway for perhaps today's session to move forward for strengthening the incorporation of equity analysis into the HTA system in India is perhaps to do some basic building block work on determining the kind of single one inequality aversion parameter that needs to be incorporated in any distributional cost effectiveness analysis. So I think that is something that perhaps the HTA needs to take forward to perhaps develop an India-specific information on this important parameter. Again, I think Prita Pawan did mention in her presentation, she showed that the value flower, the ISPOR guideline, which shows that there are many different other value domains or novel value elements that need to be considered within a cost effectiveness analysis. So while we have some traditional domains which include things like burden of the disease, QALY, or costs offset to the health system, we were doing some work in the context of vaccine in particular, and we found, based on the literature review, based on consultation with different experts and stakeholders, we found that there are many different other value domains that are relevant in the context of vaccines. And some of these which are shown on the right side. But these are things that have become even more relevant in the, specifically given the context of rising infectious diseases, which involve an assessment of looking at what is the kind of impact on reducing the further transmission of that disease. So it's not just the individual benefits to that individual who is actually using the intervention, but beyond that individual also. So the externalities of the healthcare intervention become even more important in context of these infectious diseases. And these other novel value domains have been used in a variety of different countries to different extent. So this is drawn from a systematic review, where the green color represents a given value domain in the first column, which is used in different countries, which is considered in HTA assessments in different countries. So some of these you see that these are used quite universally.
Excuse me, Dr. Sankar, one more minute, please.
Sure, I'll wrap up. So some of these are not as universally applied. But we need to perhaps take a measured consideration that which of these are important. And some of these have become quite important in Indian context also. For example, the one on perhaps the impact of any intervention or new drug, etc., on development of antimicrobial resistance, or as perhaps what Prithapan also did mention about the kind of green impact or the impact on the environmental issues, the carbon emissions, etc. So the last part, very briefly in half a minute, we need to, beyond going to other dimensions and other considerations to advance our methods, we need to also focus that the base work that we do, the foundation that we have done, is really solid and is of good quality. Two important things for every HTIN resource center and researcher who's sitting here in the audience. One, make sure that the methods that you use at the stage of framing of the question are appropriate. They are based on standard guidelines. And second, make sure that you adhere to quality standards. Prithapan mentioned that in terms of perhaps building capacity. But building capacity, alongside building capacity, we also need to consider and understand that having enough safeguards on ensuring that the quality is appropriate is also important. And we have guidelines that have been developed within India on how to conduct HT assessments, what are the different methods, etc., that need to be ensured. So that's it that I wanted to convey. Thank you very much.
Thank you, Dr. Shankar, as usual, to the point and giving us some direction of how do we move from cost effectiveness to other parameters. So as in your presentation, you highlighted that there is a need to move from ISER to net benefit, to budget impact analysis, and also to look at equity, along with the value flower that we have come across in Prithapan's presentations as well. The other message to all of us is to adhere to quality, to the standards that we have laid down for HTAI, and try to do those jobs very, very carefully and meticulously. Thank you so much for that. Now I hand over to Dr. Geet.
Now we call upon Dr. Elena Petelos, who is a Senior Research Fellow, Public Health, and lecturer in Evidence-Based Medicine and Evidence-Informed Policy at the University of Greece and Maastricht University. She'll be talking about introduction of AI in health technology methodologies.
Namaskar. Thank you, Geeta, very much. So in the interest of time, because there's very little time and I have a very difficult or complex, if you like, topic, disclaimer, I wear different hats. I'm chairing the RWE and Artificial Intelligence Interest Group at HTAI, and I'm also the Vice President for HTA at UFA. So I wanted to say that the affiliations are there, and if there's something of interest, please let us know. Then very quickly, I wanted to go a little bit more basic, because Pritakop showed the flower of 2018, but actually the flower for HTA goes back 35 to 40 years. And I think we have an inordinate focus on cost effectiveness and even clinical effectiveness, and we forget many other aspects of health technology assessment, how comprehensive it is and what we should be looking into. I think the most recent addition, of course, is the environmental impact aspect, but indeed, some of the other aspects which have to do, for example, with epidemiological data, population-wide data, are critical when it comes to building robust models and actually discussing relevance of generalizability for populations. Because of this, I go back. I think Calypso showed the definition of HTA that was developed with INATA and HTAI, but there's some provisions there, some, if you like, key considerations that are often forgotten. It has to be a transparent process, it has to be state-of-the-art methodology, and it has to look at both intended and unintended consequences, which is not always the case. And then, of course, with AI, a high level of uncertainty is being introduced, particularly because we are discussing a broader array of aspects. Equity was discussed a lot. Some people may be affected adversely, disproportionately, so the risk of harm is higher. And then an aspect that was not discussed, I think, at all was how things change depending on which perspective you take. So I've put a lot of things in the slides because I'm going to try and be very fast, and perhaps it can be useful to some of you. Now, there is a very big discussion for this session is also to focus on artificial intelligence, on what artificial intelligence is. There are hundreds of definitions around, but when it comes to pharmaceuticals and medical devices and regulation, you have to have an anchoring base. So in 2021 and up to a few months ago with recent updates, FDA came up with a definition about having machine-based systems that can, for a given set of human-defined or machine-defined objectives, make predictions and recommendations and decisions. And what's critical is that you have the perception of both real and virtual environments, turning these perceptions into models through analysis in a manner which is automated. So essentially, you're using models to formulate options for information of action, and the model is inferring things. And of course, there are many real-world examples. I think we've seen some interesting things about sensors and some interesting things about imaging, many of which generate a lot of data in the process. Interestingly enough, people often forget that beyond regulation, there's legislation. There are many new things that interplay have to do with security, cybersecurity, national policies, and even politics. So NICE last summer released its position statement, which was essentially saying that there's no generally accepted definition of AI. So you see a remit within one country, but not global. But then again, went back to define AI methodology as those that exhibit some level of adaptivity and autonomy, referring to a different kind of glossary, essentially part of the code of the parliament in the UK. And what is critical is that it had two parameters that are common, and we can be discussing them, the adaptability and autonomy. And adaptability, of course, is critical in the sense that we have black box, and potentially some aspects are not addressed by design because the tool that we may be using may decide to find, has the ability to perform in ways that were not envisioned by the programmer to start with. So may identify new patterns or not, but in an autonomous manner and in an adaptable manner. And of course also make decisions. This can be critical in aspects like clinical decision support systems that we discussed yesterday, or some of colleagues discussed yesterday, but to utilize this in terms of assessment generates algorithms which in themselves are actually devices of quite high risk. And then interestingly, what is emphasized, different phraseology but across jurisdictions, is the need to assure AI systems are effective, so have toolboxes of assurance that touch upon different kind of methodology and concepts of integrity in terms of data, so completeness of data sets, provenance, so being able to triangulate, if you like, your data sources, and of course transparency in methodology. Very few agencies have published AI or ML-specific guidelines. It's changing. Manufacturers, developers are asking for it for different reasons. Governments and assessors are also asking for it to be able to have footing in how to assess things. particularly given policymaker pressure. There are a few identifiable examples, including from the UK and also from Canada and from Australia, but there are also some developments. For example, in Japan, we have some developments in terms of committee-level oversight to facilitate the uptake of these methodologies, but at the same time to monitor their implementation. And of course, to use new methodology, you have to justify it, and in some cases, if you're using hybrid methodology, to be able to triangulate them. These aspects we have captured, and I will also come back to that briefly, in multiple webinars at the Real World Evidence and AI Interest Group at HTAI, and these are available on YouTube, and also, of course, we will be continuing with the next meeting. So in the European Union, we had very strong positioning from the European Medicines Agency, which is now becoming, given change in remittent devices, more like FDA, if you like. And when the Artificial Intelligence Act was put through the Parliament, we saw a change in the definition of the level of prescriptive detail in terms of what you should be able to provide on information about artificial intelligence. When the document went under consultation, there was a lot of push, or if you like, many requests from developers, manufacturers to say that we need to have more information on what you need in terms of data availability for modeling, use of third-party AI systems, and of course, what the provisions were for prospective testing of machine learning models. And what's important is some of these aspects could be addressed by AMA, but some other aspects should be addressed by payers. I think progressively, you may have heard, which in some areas like Scotland, for example, or we have what we call early HTA, and of course also in some places like the EU, we have early dialogue, which may be starting even at protocol design phase 1. But what is rapidly changing is also in terms of methodology, the type of data we are using to make assessments and of course to appraise. And I think in the 90s we already, those that are in the field already know that in the 80s and the 90s we already had machine learning algorithms in place, and we transitioned from random forest and vector machines and then off to pattern recognition and decision-making process across different types of decision-making. The biggest transformative thing was going from rule-based data to AI-driven approaches, and of course, what really changed things in the knots was the advent of the deep learning. And at the moment, we have, of course, everybody, AI has become, and machine learning has become a very hot topic, if you like, because of the advent of ChatGPT and a lot of interest on generative AI and what you can achieve in terms of using natural language processing. Some very interesting aspects are there, of course, for safety signal or effectiveness signal or revisiting an iterative process for HTA from electronic health records or from other types of rich data sets. And
Excuse me, Elena, you have 2 more minutes.
I have spoken 5 minutes. So I need much more than that, sorry. So of course, what's important to remember is that the aspect of opportunities is becoming more complex. So in terms of health economics and outcomes research, we have the option to have cohort selection, to look at future selection, more targeted approaches for populations, very good inference for predictive analytics and causal inference, but critically, to be able to do that, and always in a transparent and ethical manner, you need to have data. And I think this is not discussed a lot. There are very few geographies that are able to provide high quality data across the areas. So transposing decisions or methodologies without actually being able to triangulate with local data is a little bit subpar, let us say. And then for generative AI at HTA, very quickly to say that we have the option to transform information retrieval and literature reviews. And of course, this is important because you can have new search terms and combinations thereof, screening of abstracts and extracting of data, utilization of real-world data, if you have it, in terms of unstructured clinical notes and imaging, what I already mentioned. And of course, critically, some concerns in terms of data privacy and security, particularly where your population may be small or you may have doubtful provenance of data. I'm very happy to say that a few days ago we had the launch of Responsible AI and Evidence Synthesis at Cochrane. There has been already a couple of webinars. The next series starts in a couple of weeks. These are open to everyone, and they will tackle different aspects of AI methodologies, very complex. So you could actually go and see them. And very happy also because in our session we have also the environmental aspect, that the collaboration for environmental evidence is also going to be part of this. And going quickly, there's one more aspect which allows to those of you that are actively involved with these applications to look at the first early collaborative guidance generation, which is RAISE, and this could be accessible to all. And I think we look very much for feedback on what should be there for researchers working on evidence synthesis without needing necessarily programming expertise, so R Shiny and SR platforms. There's a few more. Gita, I'm going to be exactly another 2 minutes. So, there are different approaches where you have the artificial intelligence used as the main methods for analysis. This is better, let us say, tweaked to predictive systems where you have very complex systems for nonlinear interactions. And of course, we have seen AI used for hypothesis generation, but may require testing and validation with more traditional methods. And the RWD aspect also comes there, but unfortunately it's not always available. So we see limited approach so much in terms of reporting for this too. And then we have hybrid approach, which touches upon advanced statistical methodology, so propensity score estimation, matching techniques, and so on, and some more early phase aspects which have to do with clinical expertise to select covariates to be used in an AI model. Now, this is very important, it's critical, it affects how governments or payers assess things. It also should determine how developers are building dossiers. So the model validation is essential. It's becoming almost, if you like, not a regulatory, but a legal requirement. You have to be able to have verifiable data sources, provisions to allow for testing of the plausibility of the modeling. A lot of discussion is being made about not sharing raw data, but of course potentially sharing code, or at least at the bare minimum sharing assumptions that were used to conduct the extensive verification. And of course, matching what RWD, what real-world data sources may be available to be able to validate the model. And this is a critical aspect for transparency and economic modeling, which goes well beyond, of course, cost effectiveness in some of the aspects previously mentioned. What is key, and it's starting to happen, is consistent terminology, standardization, and of course, some credibility when making detailed documentation or validation efforts available. Happy to say that there's already an effort that has to do with integrity of data and matching generalizability of models, so some tracking from Europe, but also from Canada. And then just to link it and complete with RWD, you can see which aspects are discussed for cross-analysis and meta-analysis to expedite review. And of course, there's an aspect of cost effectiveness or even cost-cutting in methodology and releasing resources for conducting HTA. I would also briefly like to say that there is a very interesting initiative with Stanford involvement in the US for data provenance, and this can be very useful because there are 44 data collections with over, it was 1,800, now over 2,000 collections, data sets that can be used to allow filtering and fine-tuning data sets, so rather useful element, and it's critical generally when utilizing data to be sure we have an overview of the provenance. The data integrity was also touched upon by WHO in a very comprehensive document. It was developed independently of the documents generated by FDA or the AMA, and the focus is more clinical trial, and, if you like, or even clinical study, and less HTA, but it does affect how we extract and transform different aspects of the data sets. It does emphasize data quality assurance, and it does emphasize data preparation to be able to have machine learning workflows. Now, before I close, I would like to say that in my slides, there are some aspects that we cannot ignore. Software is becoming a medical device. Legislation is critical regarding safety. There's a lot of guidance coming out across the Atlantic. And also, in 2020, we had a few dozen AI-enabled tools. At the moment, we have over 1,000. You can see in my slides the details about this. I would like to say that there are some developments that we heard about patents, we heard about boosting the innovation ecosystem and utilizing digital technologies and AI. So I think it may be useful if these things are discussed more globally and with India being present, because some of the things I saw yesterday were extremely interesting. And of course, if in doubt for any of the things I said, you can always use ChatGPT to check it. Most of the things I've said are actually Googleable. I checked a few days ago. And then finally, I would like to say that I think it's critical. I became educator very young, and then I left academia and returned only a few years just before the pandemic. Nobody was more surprised than I was. And I think it's critical to touch upon capacity building at all levels. And I would have liked much more to have an interactive session and to hear what your needs are. So we did a full day event in Seville at HTI, and we're moving it forward with all of the things that you see on the screen. And we move it forward in Argentina, that also you heard Andres mention, to take it one step further and present what we have done for case studies with projects like AI Mind and EDITA. But we also, considering what I think I've seen, we plan to do virtual events, so I hope that all of you will submit questions and what you're working with, because it's critical in a country that's innovating so much. We move forward with adopting reverse innovation as well. My Twitter handles are no longer on the last page. They used to be there because we will not be using Twitter that much. But there are some of the sites, and we're updating the HTA site with all the webinars and all the other material that I've mentioned. Thank you.
Thank you, Alina, for taking us back to the concept of HTA and how to encompass many other petals in the flower of economic evaluation. You also highlighted on the growth of generic AI in use in HTA and on the challenges of integrating AI in HTA, the need to have AI/ML specific guidelines for easy adoption. You also highlighted the use of AI analysis in HEOR, and most important, the importance of AI model validation before integrating it in the use of economic modeling, and on the initiatives taken by various agencies for data provenance, data integrity, and use of AI in HTA. Thank you so much.
We are 10 minutes over time. If, with the permission of chair, one question or reflection from the floor can be allowed. Otherwise, we'll move to the summary part from the chairs. Any question, any reflection? We'll be allowing only one, please. Okay, I think it has, the presentations were very clear and crisp, so there are no questions from the floor. Over to the chairs for the summary, please. Thank you.
Well, thank you. I will be very brief. I think that we all see and we all feel that healthcare systems and HTA is facing many challenges. Artificial intelligence, as Elena presented, but also gene therapies, high-cost technologies. And on the other side, there are many tools for HTA, systematic reviews, cost-effectiveness analysis, budgeting impact analysis, extended cost-effectiveness analysis, equity consideration, real-world evidence. And at the same time, in low and middle-income countries, we lack trained personnel, we lack data. So we really need to be very wise on how we will use our resources. I was very glad to see all the wonderful work Thailand is doing in Prita-Porn presentation. Also, it's amazing what India is doing. I learned from Shankar and others, and I think this will be very useful also for other low and middle-income countries. I really believe that South-South collaboration is key in these matters. And my main message, I think, is that we really need to reflect about the role of HTA and how to use very efficiently our resources at HTA also. So that would be my main message.
Thank you very much, Chair. For me, I think just want to reflect the opportunity. As you can see here, we have a lot of opportunity to improve our healthcare system using data, using AI. However, we need to think what AI actually useful for. It is useful for the country like India, like Thailand, where healthcare system is we have limited capacity. So don't be afraid of using AI, but use it responsibly. That's all from me. Thank you.
Thank you so much. Now I invite the Joint Secretary Anu ma'am on stage to give away the mementos to the speakers. Now we break for tea and reassemble at 11 o'clock sharp.
to all the delegates. We break for tea and we assemble back at 11 o'clock for the next session, where oral presentations will be done. Thank you.
coffee or tea and please reassemble back to start the session on time. Requesting all participants to please assemble in the hall to start the next session. Thank you.
Hello. May I request all the participants to be seated? And request all participants on the other side to grab a cup of tea and be seated here. We'll quickly start the next session. Take a seat. Take a seat. Shima, please ask all the participants to reassemble here quickly. पहले तो उनको wait before you the chairs have to come.
Very good morning. Requesting all participants to occupy front rows as soon as possible, please. So we'll be starting our sessions of the second day, second parallel session on oral presentations by young investigators. Now I have pleasure inviting chairpersons. One of the chairperson is Professor Alia A. Suvantika. Professor Alia A. Suvantika is chair of HTA committee in FATAC, Indonesia, and he is a professor in the Department of Pharmacology and Clinical Pharmacy, Universities, Pajajaran. His expertise is in pharmacoeconomics, health technology assessment. His publication in real-world data for health technology assessment for reimbursement decisions in Asia and current landscape in a way forward and cost-effectiveness analysis in spending on research and development to address needs for innovative therapeutic products in Indonesia. We have pleasure in inviting you, sir.
Okay. Next, I invite Colonel Sunil Verma, who is an associate professor in the Armed Forces Medical College. Sir, please. He is also a member of our technical appraisal committee. Again, requesting all participants to please occupy the front rows. Please be seated.
And next, we invite even all the speakers to come on the dais and please occupy your seat. First is Dr. Dwaja Katoj, Dr. Akhil Sasidaran, Ms. Anuja VR, and Kushagra Pandey. Please come onto the dais and occupy your seat so that we will start the session soon.
Mr. Kushagra Pandey. Ms. Anuja VR. Yeah, you want to speak about it?
You speak, it's from my institute.
Okay, I will speak about it. It's all right. One more chair. Okay. Okay. So the first oral presentation is on cost effectiveness analysis of active case finding strategy to detect pulmonary tuberculosis in selected public health care facilities of the northern India. And Dhwaja Katoj from Rajendra Prasad Government Medical College, Kangra is going to present this. Over to you, Dhwaja.
All presenters, please ensure time. You have 8 minutes of oral presentation followed by question and answer.
Sure.
Thank you.
Good morning, everyone. My name is Dr. Dhwaja Katoj, and I'm working as Scientist B in Dr. Rajendra Prasad Government Medical College, Tanda, which is one of the resource center of HTA. So I'm here to present our study on cost-effective analysis of active case finding strategy to detect pulmonary tuberculosis in selected public health states of Himachal Pradesh. So these are the team members. Our study was led by Dr. Dinesh Kumar and supported by various scientists and field investigators. So talking about the background, India is the highest TB burden country in the world of nearly 27% of the global incidence. Our study gives the critical insights on the economic feasibility of active case finding versus passive case finding strategy. National Tuberculosis Elimination Program focuses on early detection of TB through active case finding and passive case finding strategy. So in active case finding strategy is the one in which the health worker proactively involves with the community to detect for TB in the individuals, whereas passive case finding is in which the patient goes into the healthcare facility on its own. So this program is guided by a National Strategic Plan for Elimination of TB. The objective of our study was cost-effective analysis of ACF versus PCF strategy to detect mainly the presumptive pulmonary tuberculosis cases in public healthcare settings. Now let's see the study's design. It was a cross-sectional study, and we took 7 public healthcare facilities in a single block of Kangra district. We focused mainly on presumptive cases. The time frame was 1 year. Now moving on to the methodology. So we adopted bottom-up costing approach, and we took various cost centers into account like human resources, consumables, and non-consumables. The second was the incremental cost-effective ratio, which was the key metric to get to know that which of the strategy was more better as compared to the other strategy. And we also did one-way sensitivity analysis to find which of the cost centers were influencing the ISO values. We also generated acceptability curve, cost-effectiveness acceptability curve, which we'll be discussing in the coming slides. Now let's see what were the key findings and the results. So as we can see in the slides, the detected cases for ACF were 1027, which were more in case of ACF as compared to the PCF. So suggestive of ACF is a better strategy as compared to the PCF for detecting presumptive cases. Now moving on to the costs. ACF was more costly as compared to the PCF strategy because it's obvious that more number of health workers and various outreach activities were involved in it. Now further, these values were calculated, and we generated an ISO value which came out to be rupees 1,915 rupees, which is the amount which is required to detect per additional presumptive case through ACF versus PCF. So the second most important finding we got was on doing the one-way WSA, one-way sensitivity analysis. We found that human resources were the major drivers, and they were basically involved in training, travel, and administration. So they were the major cost drivers which were influencing the ISO values. So let us see the simulated ISO values. So we simulated around 1,000 ISO values. And as we can see that it is lying, major of the ISO values were lying in the first quadrant, which is the win-win quadrant of the cost-effective plane. And 80% of the simulated values were cost-effective, and it was lying within the threshold, under the threshold of India, which is around 2 lakh rupees. So this was suggestive that ACF is a better strategy as compared to the PCF. So we generated the acceptability curve. So as it is seen in the graph that around 24,000 we reached a saturation, which was corresponding to the probability of 80% cost effectiveness, which means at 24,000 of WPTP per case detected, there was 80% probability that ACF is a better strategy. Now, further concluding, as we have seen in the previous slides, ACF is a cost-effective strategy for detecting presumptive PTB cases. The major cost drivers were the human resources, and the recommendations from our side was scaling of ACF campaigns are important, especially in the high-risk populations, and also to add that where health-seeking behavior is poor. So thank you.
Kindly be there. Yeah. So this study is a very well conducted study. So anybody from the audience who wants to ask the researcher about the study that she's conducted? Any questions? I think we can take at least one question, at least, if not more. Your comments on the study?
Yeah, thank you very much for your very clear presentation. Maybe I have one point to discuss further. Yes. You mentioned that human resources cost is the major
cost
driver to cost effectiveness value. From your perspective, is there any suggestion to minimize that cost in order to optimize the cost effectiveness value?
So in case of major driver like human resources are the major cost drivers. So we can do that to reduce the number of human resources which are lined in the strategy. We can do like, we can train them digitally so that there is no more pressure on the other areas. Like we need trainers, we need rooms, we need infrastructure for the trainees. So we can make a digital for them.
In fact, my viewpoint has already been summed up with this, because I was also surprised to see the HR being the main driver there.
Yeah.
So there's ample scope of getting the training done, not only on the real-time basis, maybe on other things. Thanks for your study.
Thank you so much, sir. Thank you.
Thank you, Dr. Dwaja. Now, the next presenter is Dr. Akhil Sasidaran from ICMR National Institute of Epidemiology, Chennai. He'll be presenting on cost effectiveness of rabies monoclonal antibodies in India, a decision tree analysis. Over to you, Dr. Akhil.
Good morning, everyone. Thank you for joining me today. Thank you, our chair, Dr. Olia, our co-chair, Lieutenant Colonel Dr. Sunil, and our moderators and the organizing team of this symposium. So today I will be presenting on our study related to cost effectiveness of rabies immunoglobulins in India. So rabies is a preventable but fatal disease, accounting for nearly 36% of the global deaths in India. So WHO estimates around 8,000 to 20,000 deaths due to rabies in India. However, a recently conducted study by ICMR, a community-based survey, reported 5,276 deaths in India. The study also reported a coverage of 66% for anti-rabies vaccine, but 11% coverage for rabies immunoglobulins in India. So post-exposure prophylaxis is the cornerstone for preventing rabies deaths in India. So the study was modeled based on the post-exposure prophylaxis guidelines. So following a transdermal or mucosal exposure to rabies virus, category 3 exposure, a person will undertake wound cleaning, then will take vaccination along with rabies immunoglobulins. So traditionally, rabies immunoglobulins are categorized into two: equine rabies immunoglobulin derived from plasma of horses and human rabies immunoglobulin from human donors plasma. So there are newer alternatives, rabies monoclonal antibodies, which have shown safety profile in real-world studies as well as in clinical trials. So there are some challenges associated with traditional rabies immunoglobulins. For equine rabies immunoglobulin, there are scalability issues, production scalability, and the coverage is limited in India. For human rabies immunoglobulin, mainly the cost factor is limiting. So these newer promising alternatives, rabies monoclonal antibodies, has the capacity to be cost effective. So we wanted to explore the cost effectiveness of these newer interventions in India. So the objectives were to do a cost effectiveness analysis and to undertake a budget impact analysis if it is cost effective, and to do sensitivity analysis. If the interventions were not cost effective, we also undertook a price threshold analysis to see at what price the interventions would be cost effective. So the populations were category 3 and category 2 immunocompromised exposure individuals. The interventions were rabies monoclonal antibodies, rabies shield and twin rab, and human rabies immunoglobulin. The comparator was equine rabies immunoglobulin. The outcome was measured in QALY and we represented in incremental cost utility ratio. We took a 1-year time horizon, and from a public payer perspective, direct cost, including the cost of administration of the vaccine cost, cost of adverse events were modeled in, and a willingness to pay threshold of 1 GDP per capita 2024 was taken as the WTP threshold. So this is the brief framework of our model. A hypothetical cohort of 1 lakh individuals will enter the model after a category 3 or category 2 exposure. So once they enter the model, we will subdivide them into category 3 exposure and category 2 exposure based on immunocompromised nature. Then the classification will be based on whether the animal being rabid or healthy, then whether people have undertaken wound cleaning or not. Once the wound cleaning process is undertaken, then the people will have options to, the strategy will have options to move into a full post-exposure prophylaxis or a partial or an incomplete post-exposure prophylaxis or even no post-exposure prophylaxis. So this is a detailed transition model, detailed transition for dysentery. So the key data sources for our study was actually the ICMR community-based survey. We also took clinical efficacy data from the clinical trials available globally, and the utility estimates were taken from literature search and meta-analysis. The cost data was taken from our ICMR study and market price survey, along with other costing databases available in India. So there were some key assumptions which we had taken in our model. So we had assumed the probability of survival after full post-exposure prophylaxis to be 100%. And in case of an impartial or partial adherence to anti-rabies vaccine, the probability to undertake rabies immunoglobulins would be only 5%. And we only modeled the adverse event a single time, single occurrence, and the duration of the adverse event was kept to 1 month, the duration of the post-exposure prophylaxis. So these are some of the key model input parameters which we had taken. As you can see, some are from the ICMR study, some are meta-analysis, and some have been calculated from expert opinions. So coming to our results, we found that rabies shield and twin rab are cost effective, considering a WTP threshold of 2,26,000 for 2024. Even though HRIG, human rabies immunoglobulin, has a higher QALY gain, it was not cost effective. So from sensitivity analysis, one-way sensitivity, we found that the coverage of immunoglobulins and rabies vaccination were the main were the main factors which was causing the change in ISHTA. And it was common across rabies shield, twin rab, and human HRIG as well. So the PSA results showed, the scatter plot shows uncertainty in our estimates. The plots are widely distributed across quadrant 1 and quadrant 2, and the CEAC curve was only showing a probability of 55%. So we undertook a scenario analysis to understand whether the scenario analysis, by increasing the uptake of the coverage, whether the cost effectiveness estimate changes. So for Rabi Shield, we found that even from the incremental coverage from the current coverage to 100%, the cost effectiveness estimates doesn't change and falls under the WTP threshold. But for Twin Trap, we found that it almost nears the WTP of 2024 by undertaking 100% coverage. However, for human rabies immunoglobulin, it was not cost effective under any scenarios.
2 minutes.
Yeah. So the budget projection for 100% coverage by 2028 showed that for ERIC strategy, we'll have to spend about 376 crores. And if you want to completely shift to Rabi Shield, the incremental cost would be 723 crores. So we also undertook a price threshold analysis to see at what price human rabies immunoglobulin can be cost effective. The model individual is a 60 kg weighing adult individual. So we need a 64% reduction in price for the HRIC to be cost effective at 100% coverage. So there were some limitations in our model. We had only considered immunoglobulin coverage. There are other factors, local availability, patient preferences, comorbidities, which we are not able to model. We are not able to model them. And the survival rate was assumed to be 100% if a person completes the post-exposure prophylaxis. And there could be also repeated adverse events, which we are not able to model in our study. So the conclusions are, the newer monoclonal antibodies, Rabi Shield and Twin Trap, both are cost effective at the current WTP threshold, and they offer scalability advantages over quinine rabies immunoglobulin. The budget impact for 2028 at 100% coverage was 0.17 of the projected health budget in 2028, and human rabies immunoglobulin can be cost effective with a 64% reduction in the current median market price. So these are the team members of the study, and these are the references, and thank you. And I would like to take any questions and comments.
Any questions from audience?
Somebody please give the lady the mic so that it's audible to everyone.
Please identify yourself and please try to be brief in question so that even the responses, in the interest of time.
Why only immunocompromised individuals?
No, that is the current guidelines which we follow in India. So the Indian guideline states that rabies immunoglobulins has to be given to all category 3 exposure, and for category 2 exposure only for immunocompromised people. That is based on the Indian guidelines.
Okay. So have you conducted any analysis considering the healthy individuals as well? Or will it?
No. See, all the individuals who entered in our model were with a dog bite. These were not healthy individuals. These were
healthy individuals meaning immunocompetent individuals.
They were also
yes.
They were also part of the model. We had modeled the anti-rabies vaccine coverage in them, but there were no immunoglobulin component for them. So in the decision tree, they were all part of that, but they won't have any immunoglobulins because the guideline states not to give immunoglobulins for category 2 exposure, normal individuals.
Thank you.
In the budget impact analysis, you compare total required budget with total healthcare budget, which is around 0.2%. I think it will be more beneficial if you can compare with more specific budget in the current situation.
Okay. So I believe we took it was a projection. So the annual projection we considered 5%. from the current budget, healthcare budget, we projected each year increment of 5%. And then at 2028, we looked for 100% coverage from the annual increment from 20%, what would be the projected budget impact?
I must compliment you for a very well conducted study. My query was, you took a time horizon of a year. Any rationale for that?
See, ideally the PEP schedule will be only for 1 month, but the adverse events also we model 1 month. So since we had to calculate the college, we had taken a 1 year time horizon.
Right.
We could have taken a shorter time horizon as well, but we opted for a 1 year time horizon at that point of time.
Right.
Yes.
So,
One question from there, Dr. Amit.
Did you try to look at the supply side in terms of cost to manufacture, its effects on the price that we asked?
No, sir.
You think that will be valuable?
Actually, for with cell-mediated vaccines and these newer monoclonal antibodies and all, as the production increases, the cost will come down. So we anticipate that economies of scale will work for that as well, and even if these cost estimates will be coming down as well. Thank you.
Thanks.
Thank you all.
Sure.
Okay, thank you, Akhil. The next presenter is Ms. Anuja VR, and she will be presenting on behalf of many other co-authors of this paper. And she is from Tata Memorial Hospital, and she is going to present on cost effectiveness of pertuzumab as new adjuvant treatment for human epidermal growth factor receptor 2 positive operable inflammatory or locally advanced breast cancer.
A warm welcome all. Today I am presenting cost effectiveness of pertuzumab as a neoadjuvant treatment for women with operable inflammatory or locally advanced HER2 positive breast cancer in India and adaptive health technology assessment. Introduction. Breast cancer is the most common cancer among Indian females. 30 to 40% of Indian females present with the locally advanced breast cancer. Among the HER2 positive breast cancer is associated with a poor prognosis, while anti-HER2 therapies like trastuzumab change the treatment. Pertuzumab has become an important addition, showing clinical benefits in trials like Neosphere. Pertuzumab has granted approval globally, but India lacks cost effectiveness evidence. So our aim is to build this gap by adapting international cost effectiveness evidence using adaptive HTA principle. Rationale for ISHTA. In 2019, NHA and National Cancer Grid signed a memorandum of understanding to link the optimal category of NCG guideline intervention with the HBP. For doing HTA for these bundles of interventions is burdensome, where adaptive HTA is become a potential solution. Methods. We followed NHA HTA methods manual, which is a draft version, where population intervention comparator and outcome was aligned with the Neosphere trial and supplemented by the input from clinicians of National Cancer Grid. Our population was women with operable inflammatory or locally advanced HER2 positive breast cancer. Intervention was pertuzumab, trastuzumab and taxane. Comparator was trastuzumab and taxane. Outcome was pathological complete response, invasive disease-free survival, 5-year progression-free survival, ISR per coli. Data extraction. We rapidly reviewed international economic evaluations and HTA reports. We identified 7 studies in total. There were 3 HTA reports and 4 economic studies. Data analysis. Adjustment of ISR and coli to the Indian context was using NHA HTA methods manual. These were the formulas for the cost adjustment. And these are the formulas for the coli adjustment. And India's 2023 GDP per capita, that is 2,05,249 was considered as the willingness to pay threshold. Cost effectiveness summary. Neosphere trial, which was completed in 2014, showed improved clinical benefits in terms of improved pathological complete response when adding pertuzumab to trastuzumab and taxane. Cost effectiveness summary. Among the 3 HTA reports, two were from high-income countries and one from an upper middle-income country. The 4 economic evaluations were from high-income country only. Time horizons were also ranged from 5 years to lifetime. The perspectives were also varied. They used payers' perspective, societal health system. Evidence appraisal. The adjusted ISR ranged from INR 25,644 per collie gained to 6,87,153 per collie gained. Among the 7 studies, 5 were yielded cost-ineffective result and 2 were yielded cost-effectiveness result based on the adjusted ISR. So, summary. High heterogeneity in the cost-effectiveness result of pertuzumab across different regions, which showing the complexity in the adjustment of international economic evaluations to the Indian context. Even though there were mixed evidence, majority of the studies include means all 3 HTA reports suggested the intervention is not cost-effective for the innovator candidate of pertuzumab. So, given the mixed evidence, we suggest a full economic evaluation for the generic version of pertuzumab, which has a price ranges from 61,000 to 80,000 in the Indian context. So, I acknowledge my thanks to my co-authors and collaborators from the Center for Global Development and Postgraduate Institute of Medical Education Research. Thank you.
Thank you, Anuja. The floor is open for any questions. The chairpersons.
I'm just wondering, is the price of pertuzumab the major driver to the cost-effectiveness value based on studies that you review from several databases?
Sir, most of this in economic evaluation, the major driver was the trial itself, because the trial was not provided the mature data. So all this economic evaluation extrapolated the pathological complete response to event-free survival. So that was the main driver for the cost-effectiveness result in these trials, in these economic evaluations.
I assume that all the relevant and pertinent inclusion/exclusion criteria was applied to this study. Having assumed that,
yes,
now you did mention that the generic, the biomolecule is available.
Yes, sir.
So my query would be, shouldn't it have been better if you straight away gone with the generic biomolecule rather than going for a proprietary kind of a thing?
Sir, we did an adaptive HTA for the innovator candidate because the economic evaluations were available for the innovator candidate itself. There were no economic evaluations available for the generic. So it was recently available in the market. So
where I was hinting at is, doing research is a perfectly, good exercise, but this exercise has to lead to some, implementation. So in future, one of the things that we need to take up, right up on the agenda is, we do the study which is implementable, which gives a very plausible and very verifiable results,
yes,
so
sir.
that it's easier for, at the end of it, somebody has to take a call on it, isn't it? So your job or the job for any researcher,
yes,
in HTA is to bring the evidence to that level where it is easily acceptable and implementable.
Sir, actually, sir, we did this adaptive HTA for the National Cancer Grid. So there were so much interventions in the optimal category. So the aim was to change the optimal category of interventions to link with the HVP. So for that only we did adaptive HTA for this innovator candidate, but it turned to be cost ineffective. So
yeah. Nonetheless, good effort.
Yes,
Thank
sir.
you for time. Thank you.
Thank you so much, sir.
Thank you, Anuja. So our next presenter is Mr. Kushagra Pandey from Heraletics Private Limited, and he will be presenting on an assessment of how the willingness to pay threshold will be with the application of the NICE severity modifier could change its direction. Over to you, Doctor.
Respected everyone, a very good morning to all of you present here. This is Kushagra Pandey, Health Economic Modeler at Heolitics Limited, having a working experience in cost effectiveness model in developing and adopting across a number of HT agencies, particularly for UK, for NICE and ISO at global level. Without frightening you much about my introduction, I come to my topic. Honorable policymakers, esteemed colleagues, and distinguished guests. It is an honor to be speaking with you today on a subject of great importance, how disease severity is incorporated into health technology assessment and its relevance to healthcare decision-making in India. We all recognize that healthcare resource allocation is a key point for every country, and India has been a remarkable progress in establishing an evidence-driven framework for evaluating new health technologies. HTA plays a critical role in ensuring that the most beneficial treatments are made accessible while maintaining sustainability within healthcare budgets. It allows decision makers to determine which interventions provide the best value for money and should be prioritized for funding. In many countries, including the UK, this assessment is performed by NICE, which stands for National Institute for Health and Care Excellence. NICE uses incremental cost effectiveness ratio, stands by ISHTA, which compares the additional cost of a treatment to the additional health benefits, usually measured by QALY, stands for Quality Adjusted Life Years. For years, NICE used end-of-life criteria, which allowed treatments for terminal illness to be assessed at a higher ISHTA threshold, thereby improving access to the life-extending therapies. However, this approach was too narrow as it mainly focused on treatments for patients with a short life expectancy. To address this, NICE introduced the disease severity modifier in 2022, a significant update aimed at ensuring that treatments for diseases with a high lifetime impact receive fair consideration in reimbursement decisions. Today, I will unpack this new approach and discuss how core principles may offer learnings for India's evolving HTA framework. Why was it introduced? The introduction of the disease severity modifier was driven by three key considerations: expanding the scope beyond terminal illness. The earlier end-of-life criteria only applied to disease with a life expectancy of less than 24 months. This meant that other severe diseases such as chronic illness, rare diseases, and long-term disabilities were not prioritized. Second, ensuring a more equitable approach to assessing treatments. Some diseases lead to significant health loss over a patient's lifetime, even if they are not immediately life-threatening. The new method ensures that all severe diseases are considered within a structured framework, reducing disparities in funding decisions. Third, bringing greater transparency and consistency to NICE decisions. By using a quantitative evidence-based approach, NICE aims to make reimbursement decisions more predictable and fairer for all stakeholders. Now, how does it work? So the disease severity modifier relies on absolute QALY shortfall as well as proportional QALY shortfall, whereas absolute shortfall basically means the number of years lost, the number of future QALYs lost by our patients with the given condition, while the proportional shortfall stands for the proportion of future QALYs lost by the patient with the condition. So, based on this measure, NICE has defined three cost effectiveness thresholds. First, if the disease leads to a QALY shortfall of 18 or more, the ISHTA threshold increases to £50,000 per QALY. However, if the shortfall is between 12 and 18 QALYs, the threshold is £36,000 per QALY. And the last one, if the shortfall is less than 12 QALYs, the standard threshold of 30,000 per QALY applies. This means that treatments for diseases with the higher lifetime health losses can now be considered cost-effective even if their ISHTA threshold exceeds standard limits. By incorporating long-term disease burden into decision-making, NICE ensures that treatments for severe illness are given appropriate priority in the reimbursement process. It also seems that in the end-of-life criteria, it was too narrow, so that the quality shortfall has a little bit wider the scope of severity weightages, because in the end-of-life criteria, we see that the weightage is only applied to 1.7, but in the quality shortfall, the weightage comes from 1.7 and also to 1.2 as well. Now, we are going to discuss the implications for the Indian market. India has been making notable progress in advancing its HTA framework through HTA IN, stands for Health Technology Assessment in India, with a focus on affordability, accessibility, and equity.
Dr. 2 minutes.
While our approach differs from NICE, the principles behind the disease severity modifier offer valuable insights into how can we refine our own decision-making framework. The growing relevance of severity-based HTA in India. India's healthcare landscape is diverse with varying disease burden across states and populations. Government-led initiatives like Ayushman Bharat and other reimbursement programs require robust methodologies to ensure optimal allocation of healthcare funds. By integrating disease burden considerations into HTA decisions, India can further strengthen its ability to prioritize treatments to high-impact diseases, such as oncology, rare diseases, chronic conditions like diabetes, cardiovascular diseases, and respiratory illness. Defining India's specific ISHTA thresholds for severe diseases, NICE adjusts its ISHTA threshold based on disease severity. A similar approach could be explored in India. This would enable a more nuanced, data-driven approach to HTA recommendations and funding decisions. Harnessing India's strength in digital health data and real-world evidence. India is rapidly advancing in digital health initiatives like Ayushman Bharat Digital Mission, again mentioning, and large-scale electronic health records. By leveraging real-world evidence and national health registries, India can develop more accurate, severity-based cost-effectiveness assessments. The last one is also that there's need for better application of EQ5D value sets for quality shortfall severity weights application. Now, the closing and takeaways, I would conclude this with, to conclude, NICE decision severity modifier represents an important evolution in how decision burden is incorporated into healthcare decision making. For India, this approach presents valuable insights for strengthening priority-based healthcare funding, enhancing HTA methodologies to reflect long-term decision burden, supporting India's commitment to evidence-driven policymaking. As India continues to expand its HTA framework, discussions around severity-based cost-effectiveness thresholds, quality-based approaches, and real-world evidence integration will be a key to shaping a stronger and more equitable healthcare system. With that, I thank you for your attention and look forward to your valuable perspective on this topic.
Thank you, Dr. Pandey. In the interest of time, a quick from the chairperson.
Based on your study, do you think there should be specific willingness to pay threshold for oncology treatment or rare diseases drug?
Sorry?
Do you think it is necessary to have a specific willingness to pay threshold for oncology treatment?
If it provides better results, then we should have some specific willingness to pay thresholds. Because I feel that every country is have some diversity and some different EQ5D value sets. So definitely one size fit all approach I would not think would be a better, and it's more better that we should have specific country data sets and specific country value sets as well. If it is possible, if it is feasible to have that, then we should definitely have.
Yeah. Thank you. Very clear presentation.
Thank you so much. Thank you so much, everyone. Thank you so much.
Thank you. So that, all the presenters has commented, presented within time. So now I would request chairpersons to provide your final comments.
So this has been a privilege to be able to go through the multitude of studies that came to me and for other members for, do the screening part of it. So the selected studies, they are in sync with what has been the motto for this symposium. And I'm very happy to see and note that the studies are following the rigors of scientific protocol, the research methodology, and of course, the other aspects and dimensions of health technology assessment. Having said this, I need to make a generic, remark on this particular thing. I know many of you sitting there, and probably many of us also, will take up HTA-related studies, research projects, and other things which come to us. But there are certain criteria which are to be fixed, which are the essential of it is, we got to be very, very, very specific about whether it is meeting the criteria for the HTA or no, the scope, the triad of unmet needs, the kind of the population that is exposed, the elements of equity. I mean, we can do anything, the scientific research, rigors, everything is fine. But ultimately, the most important part, as Dr. Andre has been mentioning during his course of deliberation for the previous day and today, the implementation part is most important. So we need to be aware about from whose viewpoint are we conducting the study. If we are doing the study just for our, there are always preferences that need to publish, need to make a name for myself. That's fine, all fine. But ultimately, the real value, the real dimension, the finality lies in implementation part of it. And we are well aware that the policy makers are not necessarily experts on the HTA and the finer aspects of it. So what you present to them, they'll be able to take it on with a singular objective. Do I have money? Do I have money to allocate this for the entire thing? So that brings me to the point, very pertinent point that Dr. Shankar Priyanja made prior to this session was, you need to find a suitable subset where it is most impactful. So whatever your studies are there, whatever the evidence that you've generated, it has to give us that particular aspect, whether it is implementable or whether it is not. Ultimately, it boils down to that only. Nonetheless, let's not get bogged down by so much of filters, if I may say so. Conduct the studies by all means, be independent, be absolutely free, like a free bird. Do it. But always keep it in mind that it is ultimately the end results that matter. Otherwise, we'll be following the process and not following the outcome. And which I believe both are important, but the latter part is much more important. If you really want to make an impact on the health, the policy and the health ecosystem, probably that is the thing we need to bring it into mind. With this, I sum up. Any comments from your side?
Yeah, when we are talking about the inclusion of new interventions, we are talking about accessibility, affordability, and sustainability. And through the presentation from all presenters in this session, we can see the role of HTA study can solve those three major challenges.
Thank you. With this, we are almost come to the end of the session.
So have we saved some time? Have we saved some time?
Yeah, we have
time is the most important resource. Yeah, thank you.
Thank you. So, now we take this opportunity to felicitate both the presenters and chairperson.
I thank you, the chairs, for chairing this session. Now, I would request Dr. Sangamitra Pati, Additional DG ICMR, to please come on the dais to give away the mementos for the speakers. And also Dr. Calypso to be on the dais to give away the mementos to the presenters.
I would request chairs to.
Let these people first open it. Yeah. Please come.
Please. Dr. Dwaja, please. Dr. Akhil. Anuja. Pandey.
And now the chairs.
Okay, thank you.
Yeah, we'll have a good photograph.
Please join for a photograph.
Thank you, sir. I'll get in touch with you. Sure, sure, sure. Thank you.
Shankara. Thank you. बालू कहाँ है? बालू से पूछना पड़ेगा। बालू से पूछ के बताते हैं। Hello. Hello. The next session will start as soon as possible. There is a parallel session going on in the other room, and as soon as that will be over, we'll start the next session. So it'll take about 10 to 15 minutes more. So meanwhile, before the next session starts, we request all the participants to go outside in the foyer and look for poster presentations by different researchers and academic students who have presented here. So kindly see those posters, appreciate them, and you can ask them questions. They are all around there.
ठीक है, इसमें राजीव बैल को जा चुका है, कृष्णा मैम को जा चुका है, गया नहीं आया चला जाएगा, अरुणा मैम को जा चुका है। हो सकता है इसमें दे नहीं ना, कमों में तो आधो को देगी, आधो को देगी नहीं, एक तो वो खुद ही बैठ रही तो क्या ही तो जा रहे हैं, नहीं जा रहे हैं, कल भी कहाँ गई थी, वो कहाँ ले गई थी कविता।
मुझे एक स्क्रीनशॉट शेयर किया दिए प्लीज मुझे एक पिक्चर दीजिए गेम ऑफ थ्रोन्स वो सीरीज है वो एक आध एपिसोड देखा था थैंक यू
Make an announcement. All participants are requested to be seated. The parallel session is going to be over in 5 minutes and Secretary DHR is going to be here anytime. All are requested to be seated.
we request everybody to assemble for the last way forward session. People who are there in the marketplace, kindly please assemble back into the hall. Request everybody to assemble back into the hall. We invite the chairperson, Srimati Anu Nagar, the Joint Secretary, Department of Health Research. Shri Saurabh Jain, Joint Secretary from the Department of Health and Family Welfare. We now request the chairperson to give her remarks.
A very good afternoon to you all, and so I'm very happy that we have concluded about 1.5 days of our deliberations and discussions on HTA, and it has been very useful for us as HTAIN in the Department of Health Research. We've had wonderful discussions, lots of learnings, and we've made lots of connections within the country and outside the country. And we are really hoping that there are useful takeaways from this workshop. And I'll request Dr. Kavita to make a presentation. But before that, would you like to say something? Okay. So we'll have a presentation from Dr. Kavita on the major takeaways from the workshop. Thank you, ma'am.
The 2-day-long event is now in the verge of conclusion. We just reflect back on what are our key takeaways. So from the inaugural session, we had our chief guest, Minister J.P. Nadda sir, speaking about HTA. We had all the dignitaries speaking about HTA, and the takeaways is that we need to help innovators and industries with a branding on HTA. We also need to enhance South-South collaborations. We need to ensure quality standards. We need to ensure that there is flexibility and introduction of HTA methodologies. We need to understand that HTA is a part of a strengthened ecosystem. We also need to understand how to promote HTA uptake in states. We need to understand how leveraging of digital health technologies can be done. Next slide. In the session 2, where we looked at what was the impact of health technology assessment, we understood that we need to scale up HTA resource centers. We need to replicate successful models. We also need to strengthen South-South collaborations and engaging with global health networks. We need to position HTA as a convening leader in the South-South collaborations. Next. In session 3, where we looked at integrating cutting-edge, innovative healthcare technologies into the health system, we understood that we need to accelerate health outcomes through real-world applications. We also need to foster collaboration with academia. We need to learn from Indonesia's healthcare transformations. We also need to develop a new HTA business process. Next slide. In session 4, where we looked into supporting value-based pricing and procurement of drugs through health technology assessment, we understood that we have to develop institutional structures. We also need to create contextual, appropriate, and fit-for-purpose value-based pricing strategies suitable for Indian healthcare system. A participatory and inclusive engagement process with all the key stakeholders. We also need to understand how political buy can be done in explicit government orders issued by key stakeholders. Next. In session 5, where today morning we looked at advanced methodologies for health technology assessment, We understood that we need to enhance the HTA methodologies beyond ISER and also include equity consideration, net benefit analysis, and real-world evidence. Addressing emerging challenges, we need to develop and manage AI-related uncertainties, strengthen safety and early assessment, leverage India's leadership in HTA. We need to ensure rigorous and practical approaches to develop robust, adaptable technologies that address healthcare challenges. In the roundtable discussion that we had now before this session, it was a nice roundtable with industry and innovators put together in one platform. We could actually identify how to facilitate more consultative mechanisms to strengthen the stakeholders' engagement, how the process, the timelines for undertaking HTA studies can be brought down and the HTA implementations can be strengthened, quality outcomes, not only looking at cost, clinical effectiveness, looking at what is the value and outcome a technology adds, public procurement, how HTA can be introduced or help in public procurement, early HTAs, when evidence is insufficient, early HTAs can support, an HTA evolving process that can be adapted, how gene therapy can also be utilized for undertaking HTA studies. So these were some of the deliberations which happened in the roundtable discussion which happened now. We open up, we have come to the last session where we're going to take it up as a way forward for HTA to march forward, and this is the session. Thank you, ma'am. So we now request Joint Secretary Sir Saurabh Jain sir to give his remarks.
Good afternoon, everybody. Chair of the final session, Shrimati Anu Nagar ji, Dr. Kavita, distinguished panelists, speakers, and guests who have joined for the International Symposium on Health Technology Assessment. And this is the final session which talks about the various way forwards for strengthening the collaboration between various central government, state governments, the industries, innovators, so as to ensure accessible and affordable healthcare through the utilization of the health technology assessment. As we all know, that health technology assessment has played a very, very important role in providing evidence for ensuring that the policies that we make are based on evidence, so that when it goes to the state, they are much more confident and they are much more effective in terms of implementation at the field level. As we all understand that there is always a resource constraint that is there with the state. And if the technologies can be cost effective, they can be patient effective, treatment effective, and also they are considered safe, then it will be very easier for the state to allocate resources for those sectors and improve the overall health system of the country. The HTA can support the state-level health systems by providing evidence-based recommendations tailored in local health needs. And in this respect, I would like to give the examples of the states of Tamil Nadu and Meghalaya, who have actually adopted the HTA in developing their health benefit packages and ensuring that the health system strengthening is taking place through the various recommendations that are coming from the HTA. The state of Meghalaya has also shown that the HTA can be employed in their respective state and to ensure for the health system strengthening, and how specific to the northeastern state the HTA can be customized and it can be useful in providing the affordable health care. We all, today we are all from the industries, from the innovators, from state and central governments, and it is very, very important that there has to be an effective collaboration models, including the multi-stakeholder forums, the international symposiums like this, in which all the healthcare providers, the innovators, and the various other stakeholders, they come together to discuss the HTA recommendations. as we was discussed, I was listening to the previous discussion, and one of the main challenges that being faced in the overall health system ecosystem is the distance from the policy, the recommendations to its actual implementation. And so here the importance of this kind of forums comes, where the stakeholders from various sectors, whether it's the innovators, whether it's the industry, they can come together, they can discuss, and these kind of HTA recommendations are being influenced by different perspectives, so that the distance between the policy and the implementation at the field level can be reduced, and once the HTA is done for a innovation, it can be effectively rolled out in the state. I'm looking after NHM, and one of the major roles that ISHTA has played is in terms of providing the value-based pricing to reduce the out-of-pocket expenditure, which is one of the main important cornerstones of the NHM objectives. Now the out-of-pocket expenditure, as we understand, has come down to 39%. And the role of HTA is in ensuring that the value-based pricing is by providing evidence on the clinical effectiveness and the cost effectiveness of healthcare technologies. That has helped, in fact, in the sickle cell screening program, the value of the POCT devices has come down drastically after the HTA was carried out on various innovative technologies, which is ensuring that the patients can get affordable healthcare. Strategies for integrating digital health solutions, including investing in digital infrastructure, enhancing digital literacy among healthcare providers, and promoting interoperability through frameworks like the Ayushman Bharat Digital Mission, can ensure seamless access to health records and improves the continuity of care, making healthcare more accessible and efficient. International collaborations can ensure that the HTA capabilities can be leveraged. They can be by sharing the best practices, methodologies, and experience. Learnings from the global HTA networks can help India develop more robust HTA frameworks, while sharing our own experiences can contribute to the global knowledge on affordable healthcare solutions. HTA has played a very, very important role in designing the state-level health policies, and evidence-based decision-making is actually fostered through the HTA systems, in which decisions are grounded in scientific research, data, and enhancing the efficiency and equity of healthcare delivery. States like Tamil Nadu and Gujarat have established robust HTA capabilities by investing in training and infrastructure. And this capacity building has ensured that they have stable and very robust HTA systems which can conduct studies relevant to their own healthcare requirements. HTA is used to address the state-specific health priorities. For instance, states can prioritize HTA studies on diseases that are prevalent in their own regions, ensuring that interventions are tailored to local health needs. As we see the benefits of HTA, we have to also see the various challenges that are actually there in incorporating the HTA recommendations into the actual field level implementation and the policies. And one of them is the implementation gaps that happens across the state, because our healthcare system is varied, it is different in different states, and ensuring the consistent adoption of HTA technologies and recommendations always remains a challenge across the states. The states still have very less capacity. Very few states are having the capacity to do their own HTA assessments pertaining to their healthcare needs. And in this respect, the continued investment in their infrastructure as well as their training requirement is very, very essential if the HTA recommendations can be implemented at the state level. The active participation of various stakeholders are very, very essential, like the industry, the international partners, the policymakers. That is very essential for ensuring that their assessments are relevant and they are implementable. As I have said that for that purpose, initiatives like the training programs for healthcare providers and policymakers, these kind of workshops on HTA methodologies and partnership with international organizations can enhance the capacity and infrastructure of the various states. Integrating HTA and digital health into medical education can also ensure that the future healthcare professionals are conversant and they are trained on the latest healthcare technologies. Ensuring the consistent adoption requires strengthening the regulatory frameworks, enhancing stakeholder engagement, and fostering a culture of evidence-based decision-making at the state level. That is very, very important if the ISHTA has to grow further in our country. This also ensures that the data systems are very, very robust. All the decisions are based on the data generated from various implementation of various programs, and for that, investment in the digital health infrastructure is very, very much required. These interoperability frameworks through the Ayushman Bharat Digital Mission is very, very important so as to ensure the integration of health records so that the continuity of care can be established and the ISHTA and it can provide much more efficient healthcare systems. Strengthening the regulatory frameworks involves creating clear guidelines for technology assessment, ensuring transparency in decision-making process, and fostering collaboration between the regulatory bodies and the ISHTA agencies. ISHTA can also ensure equity in healthcare by evaluating the cost effectiveness and accessibility of health technologies in different settings. This can help the policymakers in prioritizing interventions that are most beneficial for underserved population, enhancing the healthcare access and equity. In fact, ISHTA, the ministry has placed a very important priority on the ISHTA. In fact, in our recently conducted Manthan Shivir of the ministry, one of the main items of discussion was the involvement of ISHTA in providing accessible and affordable healthcare. So, in the end, I would just like to commend the Department of Health Research for organizing this workshop, this international symposium on ISHTA. This has come at a very appropriate moment. And I hope that the ISHTA, from this workshop and from the 2 days deliberation, various ideas, various suggestions has come forward, which will guide our policies and the implementation frameworks that will continue to support the various objectives of the universal health coverage, that is providing accessible, affordable, and equitable health cover. And it will also continue to support the National Health Mission in formulation of evidence-based policies, which the states can adopt and improve upon their healthcare systems. So I once again congratulate all the organizers and all the stakeholders which are present today in this workshop for ensuring that the ISHTA can be incorporated in our overall healthcare ecosystem to improve the accessible and affordable healthcare. Thank you very much.
Thank you, sir, for nicely bringing out the importance of HTA in evidence-based decision-making. We request the chair and the joint secretary to launch our policy brief book volume 3. We brought out the earlier 2 volumes in the previous international symposiums, and we request you to launch our volume 3 policy brief books. Thank you, ma'am, and thank you, sir. We now request the chairperson to give her remarks.
Again, a very good afternoon to you all. And I'm really delighted to see all of you here on a Sunday afternoon. And this really speaks about how HTA is now going to emerge as a big player in our healthcare sector now. And with this, I'm convinced what our Honorable Minister said yesterday about building a brand HTAIN. And I see that it is apt time and we must move ahead on that. And I hope that we all today resolve to building this brand HTAIN. So this is Health Technology Assessment in India. So a very big takeaway from this workshop has been scaling up of HTA. So it would be our endeavor that we move from 25 resource centers to 100 resource centers as the Secretary had promised yesterday. We would be working on that. We need to have all these resource centers, we need to be methodologically, we need to really be very robust. We are working in the right direction, but we need to kind of streamline our processes, be more transparent. And as somebody in the said in the industry interaction, that we need to have very clear timelines, because for an innovator or for a program, it is very important that he has a timeline, because people can't wait for years for their recommendations. And for that, we'll have to work on adaptive HTAs, provisional HTAs, or whatever methodologies we can think of. A very big learning from today's session has been that there have to be lots and lots of consultations. And I remember that when I had entered into the service, one of our directors of the academy said that what you need to learn is to communicate, communicate, and communicate, which is very true for HTA also. We need to talk to people, we need to have a lot of interactions with the innovators, with the state government, amongst ourselves, and we really need to build this capacity. And that Shri Saurabh has been here is a testament to the fact that we have been working at least within the ministry, and we would really like to strengthen this relationship of HTA and NHM further. We've been working with NHM, we've now started working with Department of Pharmaceuticals also, and we would be really now also interacting a lot with the industry. When we talk about interactions, consultations, it's very important that one of the recommendations that we got was that now we have to work on South-South collaboration. You know, we have to kind of, we are now in a stage wherein we can also help others to build up their own HTA bodies, and we can have joint projects, and we don't really need to do, if we have a similar scenario, we really don't need to do all the things over and over again. So we need to work on that. We need to work with other HTA and associations. There have been lots of learnings today from the speakers from Argentina, from Indonesia, from Philippines. It has been really great. We've been able to capture your successes and your strategies, and we would like to really adapt the way we can do that in our Indian way. So we really need to talk more to them, learn with them, and we would really like to participate in the next conference, like Dr. Andrew said. We would really like to come to Argentina and kind of showcase what we've done here in India. One of the learnings for me in this session has been early HTA. So we need to work on HTA on a life cycle development of a technology. It's not that we do HTAs only at the end when the product is ready, but maybe we can also think about early HTAs and how we can help have cost-effective, clinically effective technologies. We had a very good discussion on value-based pricing, and we made this very clear that when we talk about HTA, it's not just cheap technologies. It's what we mean is we talk about cost-effective technologies. And we had very good examples today and very interesting ones from Thailand when the speaker talked about the dental implants, that it was because of equity that they could not take it up, although it was cost-effective. So it's not just cost that we are thinking about. Here in our scenario also, there are different considerations that we need to consider when we take up HTA. We would have to take HTA into telemedicine because, as Secretary Health mentioned yesterday, that for accessibility, it's very important that we strengthen telemedicine in the country. And for that, we need to have technologies which are compatible with that. And we really need to work on HTA for these AI-based technologies. And I'm sure we would be working on that after this. So overall, I think it has been a wonderful learning. You have been great participants, and we hope to meet again next year on a similar scale. Thank you very much.
Thank you to the chair. Thank you to Joint Secretary Saurabh Jain, sir, also. Thank you to all the organizers. Thank you to all the delegates. With the permission of the chair, we would request if the HTIN team can come up and for a photograph with everybody. The team has been working sleepless nights for the past 2 to 3 months. Every single person has contributed to what has happened in this 2-day symposium. Request the HTIN team to please come up.
So I had to do this in the end, but somehow I forgot. But I really compliment the team HTIN here, all the resource centers, the headquarter team led by Dr. Kavita. They have spent sleepless nights and really working all over on this. So I think we need to give a big applause to them. Thank you. Ajay, let's have a photograph.
Dr. Geeta, Vipin. Now we may request all participants to come together. We may take a group photo. That is left to the group photographers how they want to take it. Maybe we request everybody to come forward. We can have a together group photo with all the participants, the delegates, the resource center people, the academicians, the industry partners, and everybody.
ठीक है दूसरे ग्रुप में आएंगे दूसरे ग्रुप
Next is Amit.
Typically love to lead.
All resource center participants and hubs, please come on the stage for a photograph with the Joint Secretary. Only the resource centers, hubs. Jaldi aao, jaldi. Quick, quick.